Hi everyone, my name is Jose Ramirez Del Toro, and I'm a physician in non-surgical sports medicine, and I wanted to talk today about osteoarthritis. There's lots and lots of misconceptions regarding osteoarthritis, and I wanted to just run a few of those by you and talk to you about the myriad of things that can be done for arthritis. In my practice, I hear this scenario all the time. Patients walk in and they've been told they have arthritis, and they've been told to just come back when it gets bad enough for a joint replacement. I've also heard the scenario where patients have come into my office and have had injections of some sort to try to help the pain, and the injections aren't really working anymore, and they've given the option. They've been given the option of a joint replacement, whether it's the hip or the knee or the shoulder. I contend that there's tons of things that we can do from the onset of the diagnosis of arthritis to when or if you would even need to get to a joint replacement. And those are the things that I feel we should be talking to our patients about. I believe there is a way to slow down the progression of arthritis. So the first thing we have to talk about is, what is arthritis? Arthritis is disease of the cartilage. The cartilage is a thin layer at the end of the long bones that sits at the level of the joint. The cartilage over time will start to wear out. That happens for many, many reasons. I'll get into a couple of those today. It could be injuries, or it could be other things that we'll talk about. Once that cartilage wears out, the joint then tries to fight that process, and often pain ensues. The interesting thing about arthritis is that I've seen patients in my office who have severe arthritis and very little to no pain, and vice versa. I've seen patients in my office who have what appears to be very little arthritis on an x-ray and even MRIs that don't show focal cartilage defects, yet they're in a severe amount of pain. So if you really want to look at this closely, it's probably not the amount of arthritis that's causing pain. It's probably something else going on within the joint. Now, that's not to say that people who have severe end-stage arthritis, that arthritis isn't going to be causing pain, but I see it all the time, patients with a significant amount of arthritis who are pain-free in my office. The factor that I believe, and many physicians believe now, that is responsible for causing pain in arthritis is inflammation. I believe that the people who have the severe amount of arthritis and very little pain probably have very low levels of inflammation, and vice versa. The people who have very little arthritis and severe pain have tons and tons of inflammation. And so what I try to talk to patients about is, what can we do to fight inflammation to hopefully slow down the progression of arthritis? And make no mistake about it, we can slow down the progression of arthritis. I know we're often told it's an irreversible process and there's nothing we can do. That's just a fallacy. That's not true. Can we reverse the process? I'm not sure, but we can certainly stop the pain from arthritis. So what does it matter if we have a lot of arthritis if we're able to function and be pain-free? So what I first talk to my patients about is things that I can help them with to decrease inflammation. The first is oral non-steroidal anti-inflammatory drugs. That includes Aleve, Motrin, ibuprofen, and those medications. I'm not a huge fan of those medicines, but they do serve a purpose short term. They can have other side effects. They can affect the stomach lining. They can increase blood pressure. They can affect the kidneys. So I'm not a huge fan of those medications. Another thing that I talk to patients about is topical non-steroidal anti-inflammatory drugs. I like these a little better than the oral ones, one of them in particular, Voltaren gel, and then there's a patch that has the same medication that's in Voltaren gel. These medications are delivered transdermally through the skin, and the systemic absorption therefore is much less, so these patients are not usually at risk for the same stomach issues and other issues than you would be if you're taking this by mouth. A third thing that I try to talk to patients about and counsel them about is taking joint supplements. These include glucosamine chondroitin, fish oil, hyaluronic acid. There's been mixed feelings about this, and most of these are not regulated by the FDA, but that does not mean that they can't be effective. What I explain to patients is when you see an old dog, for example, and that dog is limping around, any veterinarian who's watching this, or if you've taken your old dog to a vet, what they give these old dogs is glucosamine chondroitin, and within 1 or 2 days, that dog's running around like a little puppy. The canine joint and the human joint are no different. It's a cartilage joint, and they really aren't different. So the question that has to be asked is, why is it that the glucosamine chondroitin works in animals, and then there's been studies in humans that say it does not work? And I contend that it's because that puppy doesn't live in the future or in the past. It lives in the present, and it doesn't. All it knows is that it feels good. Humans have this thing between our ears called our brain, and that can actually modulate whether things work or not based on our experiences. So if we've been told that glucosamine chondroitin doesn't work, then we believe it doesn't work. But make no mistake about it, you see a dog running around like a little puppy after they've been on glucosamine chondroitin, there is some potential benefit to that joint. The fourth thing that I talk to patients about is injections, and there are several different types of injections. One injection is corticosteroids. That's been used over the years significantly. I tell patients that typically with a corticosteroid injection, they will get fairly immediate relief of the pain, and it will be somewhat short-lasting, anywhere between 6 weeks and 3 to 4 months. So the advantages of a corticosteroid injection would be that you get fairly quick relief. Disadvantage is it's short-lived. Another disadvantage is there have been studies showing that potentially corticosteroids can be chondrotoxic. Chondro means cartilage. Toxic is toxic. So this medication potentially could be toxic to the very cartilage that we're trying to protect. So I usually reserve this for elderly patients who are in severe amount of pain and just want something done that day to help them get through the day, but I make sure to tell them this isn't going to be the only treatment that you're going to receive. Another injection is injections of hyaluronic acid. I mentioned hyaluronic acid a bit ago, which you can take orally. You can also get it injected into your knees. It's usually a series of 3 injections. One company has a 1 injection profile. Maybe another company is now coming out with 1, but mostly it's a series of 3. And these don't kick in right away, so you don't start to see the relief until after the 3rd injection. But they could last 6 months to a year or longer. I've had patients that we've been doing these hyaluronic acid injections for a while. The advantage of these hyaluronic acid injections is that they're very safe and they're very long-lasting. So I prefer these over the corticosteroids. Disadvantage is that it's a series of 3 injections, and a lot of patients don't like needles. I don't know who does, but the third type of injection that is now being used is what's called Ortho Biologics. Ortho Biologics is a fairly new branch of medicine to the orthopedic world. It's been used in other medical fields for a long time. But what it is using your own products to enhance your healing. And 2 types of injections have been used. One is called platelet-rich plasma, and another is stem cells. Platelet-rich plasma is your blood is drawn, it's spun down, the platelets are then removed, and they're injected back into a joint. Platelets are involved in all 4 phases of healing, including the acute inflammatory response and then the subsequent anti-inflammatory effects. So platelets work very well in healing injuries, and so what you do is you get a super concentration of those platelets and you inject them back into a joint. PRP is used with good success into tendons and with fairly good success now into joints, looking at the literature. The problem with the PRP research is that it's not standardized at all. So there's different concentrations and different amounts, and so there's some debate about this in the literature. The other problem is insurances do not cover it, so there is an out-of-pocket expense. Stem cells are another potential orthobiologic that you can use, and stem cells are found within your own bone marrow or adipose tissue. Stem cells are cells that can become anything around them, theoretically. So you would draw the stem cells from the bone marrow or the adipose tissue, you spin them down and concentrate them and then inject them back into a joint. This is also still in its infancy of being researched. But the way this theoretically works is that it regrows whatever's around it. In the Petri dish, we've been able to put a stem cell next to cartilage and show it become cartilage tissue. In animal models, we've been able to show stem cells become cartilage tissue. We can't say that that's been seen yet in human studies, but that's the thought anyway. Some people inject PRP with the stem cells to enhance that the effect of the stem cells as well. So I've gone over with you all the things, all the potential different things that I could do to you or help you with to combat that inflammation. But what really helps in an arthritic joint are changes that you make. Make no mistake about it, you cannot fight arthritis if you're not involved, if you're not taking the right steps. The most important thing you can do, one of the most important things you can do is weight loss. Skinny people get arthritis, and I'm well aware of that, but studies have shown that weight loss is the best way to, or is one of the most effective ways to decrease the pain from arthritis. For every extra pound you have on is 4 pounds of pressure with every step that you take. So that means that if you have 20 extra pounds on, with every step that you take, you're putting 80 pounds of pressure across that joint. The average American walks 5,000 steps a day, so it's just simple math. In one day, from 20 extra pounds, you could put an extra 40,000 pounds of pressure across that joint. Multiply that day after day after day after day, and you can see how it's not good for the joint. So weight loss is extremely effective. I'll often get the argument, Doc, I can't lose weight because it hurts and I can't exercise. I do not believe that you have to increase your amount of activity at all to be able to lose weight. I think it's helpful, but I believe there's a way to lose weight without necessarily increasing that, and that's where dietary changes come in. I'm a big proponent of really going through your diet and seeing what things you're taking in that are not allowing you to lose weight, and more importantly, things that are actually probably inflaming you. So there's a type of diet called the anti-inflammatory diet that I encourage people to look into. There's a lot of literature that's been researched about this, and it basically involves removing things that are potentially toxic and inflammatory and eating things that are anti-inflammatory. I won't go into it any further, but suffice it to say that in this country where we live in the land of plenty, our rates of arthritis as we get older skyrocket, whereas in African and Asian countries where they don't have access to the same things that we have access to, as they get older, they don't have nearly close to the amount of arthritis that we have, and most of those folks are laborers and they're loading their joints. It would stand to reason that they would be worse off, but they're not. And so I believe that it's due to lifestyle and the fact that we eat certain things and we sit around and we do certain things. I don't think you should eat anything that you look at that label and you can't read what's on that label. And I believe we should all be making healthy eating choices. So this is probably one of the most important things you can do to slow down or arrest the progression of arthritis. A lot of people go out unknowingly, right? Eat whatever they want to eat and inflame themselves, and then they have joint pain and they think it's the arthritis, so then they rely on that ibuprofen or the Aleve to make them feel better. Then they eat whatever they want to eat. Then they take the pill. So they're taking this anti-inflammatory, and what they're actually treating is their eating habits rather than the arthritis, because I believe that that's what's often inflaming them. The final thing that I want to talk about today is exercise, and this cannot be overlooked. Plenty of studies have shown the benefits of exercise for an arthritic joint, and when I refer to exercise, I'm referring to both cardiovascular, but more importantly, strength training. You can build up the muscles around that joint to support that joint, and not just that, you can build up the muscles of the kinetic chain to enhance proper movement. Without our muscles, which there's about 800 muscles, the bones are just a bag of bones. Those muscles set the bones, set the joints, move the bones, and move the joints. So we can enhance all of that through the right exercise regimen. And then after we've exhausted all these different options, then, if it's time to get a joint replacement, at least that's an option in today's day and age that patients seem to do fairly well from, particularly hip replacements. But, surgery is also fraught with its own set of problems and risks. So I encourage everybody to take these steps to try to better themselves, help themselves. There's also anti-inflammatory supplements you can take, which I encourage folks to do. Thank you very much for listening, and go out and make yourselves better.